Good morning, and thank you so much to SERAM and Rankin Ray, particularly Dr. Nunez and Dr. Luna, for inviting me to lecture you today. And I see I didn't scare you from yesterday. Some people are back this morning. We are going to be talking about pelvic inflammatory disease. And to understand just the basic of pelvic inflammatory disease, it's an ascending infection of the genital tract, and it arises from the level of the vagina up into the cervix, into the upper tracts, and can spread into the fallopian tubes and out into the peritoneum to make a big mess in diffuse peritonitis and Fitzhugh-Curtis. So each year in the U.S., 1 million women experience pelvic inflammatory disease, and over 100,000 women become infertile because of the scarring due to pelvic inflammatory disease. And we do know it causes chronic pelvic pain and has a risk for ectopic pregnancies. And the risk factors include having a young age and multiple sex programs. We commonly think of the bugs for pelvic inflammatory disease to be gonococcus or chlamydia, but keep in mind the majority actually is related to polymicrobial bugs, and they're associated with bacterial vaginosis. And particularly in the older women who have PID, it's not necessarily always sexually transmitted bugs with patients who are older. Any reason to have scarring in the pelvis from diverticulitis or Crohn's or such can lead for superimposed infection on the tubes. So in that population, you don't want to scare the woman, you don't want to scare the husbands and say it's sex-related bugs, but it really is just this polymicrobial bugs. IUD users are prone to actinomyces, and we'll talk about that, and other types of atypical infections. Other things that may cause changes to the pelvic organs is when you have a disease around it, like a perforated appendicitis or appendicitis that can extend to involve a abscess or inflammation to the pelvic organs, and sometimes it's a big mess. This is a patient, for example, who has a perforated appendicitis that had a pus and extensive disease to her pelvic organs. The ultrasound features of pelvic inflammatory disease should be evaluated with ultrasound first. It is the modality of choice. It's very quick. There's no radiation, and we are able to evaluate very nicely the adnexa quite thoroughly. We look for these low-level internal echoes that are within these dilated tubes. Low-level internal echoes is either blood or pus, and they will have echogenic fat that is inflamed around it, and that's the other feature. But you're looking for these clumped fallopian tube. The endosalpingeal folds are clumped, and so on cross-section of it, it's a very nice look of what these tubes look like, and can be confirmatory on ultrasound. On CT, lots of different features that happen with pelvic inflammatory disease, where the bugs of the fallopian tubes exude out. You get a thickening of all the pelvic floor ligaments. There's free fluid, and the key is to have this very mild fat infiltration to the pelvic fat. That's quite common. In fact, sometimes you see a big cyst and you don't know, is it a ruptured cyst or is it an infected cyst? I do look at that pelvic fat as a helper to help distinguish the two for me. MRI is also good in evaluating pelvic inflammatory disease. It's not well studied in terms of it being a system, but we do see it very well anecdotally. It looks like any other abscesses in the belly, where the abscesses will restrict diffusion. They will have peripheral enhancement, and they will be T2 bright on imaging. So let's talk about the early changes of pelvic inflammatory disease. Remember, it's an ascending infection arising through the endocervical canal, and sometimes you'll just see indistinct fat around the cervix, and maybe even some fluid collections that are developing within the endocervical canal. On ultrasound, much better seen in pelvic organs, showing the developing of these fluid collections. So early PID, it can be just cervicitis, and on physical exam, that's usually what they feel clinically. As the inflammation extends up, it goes along the endometrial lining, and on ultrasound, you can see extensive hyperemia to the adjacent myometrial fat, and even thickening in fluid or debris within the endometrial cavity. Here's some gas, for example, in the endometrial cavity that you could see on imaging. Well, who gets endometritis? Well, you can have it from the spectrum of rising ascending infections, but you want to think about it in your patients who have just had pregnancy, patients who just had a DNC for abortion, or patients who've had other risk for infection. We look for a boggy uterus, hyperemic endometrium on imaging, and sometimes you'll see fluid or gas within the endometrial cavity. Early stages of pelvic inflammatory disease also extends into the tube, and you might not see a fluid-filled distended tube. You might just see a mildly enhancing tube that is not that impressive by imaging, but that is the feature of early PID, early involvement of the fallopian tubes. On ultrasound, you might see them as thicker walls. They're filled with low-level internal echoes, a little bit of fluid in it, but not as impressive as a pus-filled dilated ampullary portion of the tube, like what you would see here. In the late pelvic inflammatory disease, you're moving towards pyosalpinx, and pyosalpinx, very angry tubes that are full of low-level internal echoes. You could see the dirty shadowing the fat around the tube, that this is all echogenic fat that's also hyperemic. One of the features that this indeed is something causing significant issues. As the tubes get inflamed, they can spread to the adjacent ovary, it can spread into the adjacent pelvic fat, and even can cause pus with endometrial cavity. So in the late inflammatory disease, you will see sequela and sequential evolution of larger tubes that are full of this pus. What we can see on imaging, including CT and MR, the later stage of pyosalpinx, that the tubes are very inflamed. You see that there's adjacent pelvic fat. And even on MR, we're quite good about showing inflammation of late PID. Here are different patients showing advanced pyosalpinx. And when a tube is cut in cross-section, they actually look like small cysts together. And if the cysts are different sizes clustered together, you want to make sure you elongate them on multiplanar views or coronal or sagittal views, because sometimes you'll call this cystic adnexal mass, but when you elongate them, you can see nicely that it is an inflamed tube rather than a mass per se. And this is what I mean, is you have a cluster of cystic masses in the pelvis, but if you look at it, it is different sizes, and if you cut the tube on cross-section between the interstitial port, the isthmic portion, the ampullary portion, the fallopian tube, the fimbria, you get all these different sizes. And that's one helpful hint, that different size cysts probably is a tube enfolded on itself. On MR, very similar features where you can interrogate and elongate these inflamed tubes, peripheral enhancing. Many times you'll see the edema and the adjacent pelvic fat. So it is sometimes great to help in differentiating a complex adnexal mass on ultrasound. MR can be quick to confirm that this is indeed just an inflamed tube. On MR, you see these inflamed tubes. It's not impressive, they're not big, but you can see what is happening on imaging. It does restrict diffusion because it's inflamed, and you could see that there is also edematous fluid, and probably even a peritoneal inclusion cyst, because these are the fibrin strands that occur late ongoing after the inflammation exudes out of the fallopian tube into the peritoneal cavity. Late stages of pelvic inflammatory disease can result in liquefaction, or the pus within the tube being resolved, but now full of fluid. The fluid is obstructed in the tube. That's why they still look like it's a tube, but it's more anechoic. Again, you want to unfold the tube to make sure that you don't call these cystic adnexal masses, but rather hydrosalpinx within it. So on the chronic stages, the cogwheel appearance also comes into play. These are the endosalpingeal folds that are clumped on transection on all these patients. These are all patients with hydrosalpinx, or confounded or complex former pus-filled, but now all just fluid-filled tubes. On MR, the hydrosalpinx, very similarly, they're just fluid-filled tubes. They won't enhance, and they won't usually restrict diffusion if it's just a non-inflamed hydrosalpinx. So just moving on to advanced pelvic inflammatory disease, you could see as the bugs exude out into the peritoneal space, they can basically cause necrosis to the ovary, et cetera, and we have these tubo-ovarian complexes and tubo-ovarian abscesses that develop. But then there's spread of this inflammation and spread of the bugs up into the peritoneal cavity and around the liver. It can be quite problematic if you see an abscess here and you don't know if it's a diverticular abscess, appendiceal abscess, a tubo-ovarian abscess. Sometimes it is a matter of treating that patient. Sometimes even if it needs to be drained, if it's a frank abscess, and then follow up to evaluate what the source is. The tubo-ovarian abscess is really a late complication of pelvic inflammatory disease, about 15%, where there is destruction. It's basically necrosis of the fallopian tube and ovaries that are replaced by fluid-filled abscesses or fluid collections in that liquefaction of the nexa. And it's a problematic. It's quite morbid on these patients. Many of them have to lose their organs after treatment for resection, and many of them do have hospital stays to receive intravenous antibiotics to take care of this advanced pelvic inflammatory disease. The ultrasound features is you're not seeing any normal appearance of anything. No normal ovary, no normal tube. It's basically replaced by these multilocular collections with peripheral flow, but basically liquefied inside of different areas of pus. And you could see the hyperemic fat adjacent to the inflamed adnexa, a very good marker that you're dealing with extensive inflammation to the pelvic floor. The ovary and fallopian tube is really, you can't tell what's the difference. All you have is a pus-filled collection in the right lower quadrant. Maybe you can say it looks like a tube, but basically it's kind of replaced by liquefied abscess formation. Many patients here, many sequential patients with tubo-ovarian abscesses on imaging. Sometimes you'll see gas with the collection. Sometimes you don't. It just may be a peripherally enhancing, very markedly inflamed adnexa. On MR, very similarly, we see very nicely advanced tubo-ovarian abscess and tubo-ovarian complexes. You could see that they're T2 bright. They will restrict diffusion very avidly, just like any other abscess in the body will restrict diffusion. You could see many times also the adjacent to pelvic edema that also may mildly restrict diffusion as well. As we talk about peritoneal involvement of the bugs, keep in mind the gonococcus, or the bugs, come out of the fallopian tube. They cause significant inflammation to the pelvic floor and pelvic edema. The woman lays down, goes to sleep, the inflammation goes up into the right upper quadrant, and a perihepatitis ensues. And many of these patients can present with right upper quadrant pain when they have pelvic inflammatory disease. If you were to scan the patient at a nice early or late arterial phase, early venous phase, You might see the line of inflammation along the capsule of the liver. This is what we call the perihepatitis, the equivalent of Fitzhugh-Curtis on imaging. It's believed that these occur, this is the inflammation that you see with the violin strings adhesions in these patients. And they can be quite dramatic on laparoscopy, where they are very good at seeing the extensive adhesions from the bugs along the capsule of the liver. And that is the Fitzhugh-Curtis that we know of. So here, for example, is 2 different patients that we were able to scan late arterial, and you can see what happens to the Clissen's capsule, which is very inflamed and hyperemic. That tells you there is a perihepatitis. And so when you see that, you look at the pelvis and see what's going on it. And it can be dramatic, it may not be dramatic. This is a patient who has just significant endometritis, where you have a very hyperemic endometritis, but really the tubes themselves are not that inflamed. But this in itself has some fluid in the pelvis that goes up. She lays down, and it then causes that trickling to that capsule of the liver. A patient where you have extensive tubo-ovarian advanced pelvic inflammatory disease, very hyperemic pyrosalpinx bilaterally. And again, looking at that liver surface, you can see very nicely the capsular enhancement of Glissen's capsule. And this is Fitzhugh-Curtis syndrome. And again, quite dramatic on laparoscopy when they do look at these patients, adhesions everywhere from the bugs due to when they try to clean out this disaster of a pelvis. This one probably won't do well with just antibiotics, but sometimes have to be cleaned out by laparoscopy to take care of them. There is something that you want to keep in mind in patients with IUD users, and that's actinomyces. Actinomyces is a normal bug that we have. It's in our mouth, it's in our gut, and it is anaerobic bacteria, but they are bugs that behave. They don't usually cross any fascial plane unless there is some sort of tissue destruction that allows the bugs to cross. So sometimes we see head and neck cancer resections, they have actinomyces. Sometimes you'll see a chest wall infection and then actinomyces occurs. Well, the same thing happens in the pelvis. The presence of IUD allows for colonization to go on the IUDs, and most of the patients don't have infections, but indeed most of them are colonized by actinomyces. And when you have the infection, it becomes a big disaster. It crosses the fascial planes, becomes quite fibrotic. It looks like cancer on imaging, and it's a big fibrotic mess for the surgeons. So, for example, this one's more of an acute phase where you can see the IUD in place. She does have a pyrosalpinx in that nexa. She has peritoneal enhancement and fluid into the but this was all actinomycosis in these patients. Here's another patient, and I call them, they don't respect boundaries. Once you have an infection or a colonization of actinomyces, you are at risk for having infection. So keep in mind, 2 to 4% of IUDs are colonized. So the presence of all your women who have IUDs, you have actinomyces colonizing those IUDs. There's a reason why the women have to change the IUDs every 5 years. There is a reason why they have to change them every 5 years, because of the risk of the colonization of actinomyces. And once colonized, usually do fine, but some of them do eventually get infected. I misspoke. 1 out of 4 IUDs are colonized, 2 out of 4% get infected. And when you become infected, it's a big mess. Tubal ovarian abscesses, complexes, big pelvic floor disease process. Here, another thing that's quite rare is tuberculosis in the GU tract. Thankfully, we don't see it very often. We do usually have a history of somebody coming from a different country or such, or for patients who are reactivated with involvement of the fallopian tubes. And typically they result in these irregular short segment strictures and tubal occlusions. It's a very unhealthy fallopian tube, not something that will ever hold a pregnancy in these tubes because they're very markedly strictured. It can form significant tubular varying complices, and you don't know what the bugs are until it's been cultured, but this is a patient that had extensive tubovarian abscesses, fallopian tubes, and a very dirty shadow fat from tuberculosis. Here's one on MRI. You can see the extensive involvement has tubovarian abscesses and inflammation, but you have peritoneal disease and inflammation that comes out of the pelvic floor. So just very quick, what happens with complications of pelvic inflammatory disease. One thing that you want to keep in mind is the gonadal vein is at risk to be inflamed, infected, and when it's infected, many times it's associated with clot. And it's not supposed to be called thrombosis in the setting of infection. It is actually thrombophlebitis. That means that the doctor needs to treat the patient with both anticoagulation and antibiotics to have adequate treatment for infected thrombophlebitis. And you will see these many times after pregnancy, after cesarean section, when you are asked to image them for postpartum fever. This is what you are trying to look for. And believe me, they will propagate if they are not taken care of both by anticoagulation and by antibiotics. I have seen even pulmonary emboli from ovarian vein thrombophlebitis. We look for the distended vein, peripherally enhancing, inflamed, that extends from the large gonadal complex, typically in the postpartum uterus. Other things that can occur in pelvic inflammatory disease is pyometra, or infection to the endometrial and the uterus itself, and it usually is due to a retained fluid body. These two patients are older; they're 80 years old. This one, for example, had a retained IUD for many years, and you could see that the pus-filled abscess that replaced the uterine cavity. And this one was just a patient who was septic and actually had septic endometritis from her diabetes. Here is a patient postpartum, and this is what we are asked to many times after delivery to look for these changes of infection, abscesses, endometritis, ovarian vein thrombophlebitis, by looking at the C-section defect, the inflammation that exudes out into the space of Retzius through the area of the Phanon-Steele incision in these postpartum patients. And that is the end of my talk, and I do love GI, and we'll take questions at the end.